For over 100 years, the Philippine Women's University has been known as a leader in quality education. In 1934, PWU moved into its main campus on Taft Avenue, and since the 1970s has been co-educational. Located in the heart of Metro Manila, it is easily accessible by public transport and surrounded by affordable housing. PWU School of Nursing has been offering high-quality, student-centered, and innovative nursing programs for over 6 decades. PWU's graduate programs upgrade the qualifications of nursing professionals, allowing them to advance in their chosen fields in the Philippines and globally. In the allied health fields, PWU pioneered in programs such as pharmacy, which was established in 1926 to train students who want to succeed in any aspect of pharmacy services. The first women doctors polyclinic in the Philippines was set up in PWU in 1951. In 1986, PWU's Bachelor of Science in Nutrition and Dietetics became the first nutrition program to be accredited by the Philippine Association of Colleges and Universities. PWU was also the first educational institution in the Philippines to focus on the prevention of acute illnesses and chronic diseases through its Master of Science in Clinical Nutrition program taught jointly with the St. Luke's Medical Center. PWU School of Medical Technology offers a competency-based curriculum enhanced by intensive training in clinical laboratory procedures. Offering a Bachelor of Science in Medical Technology and a Master's program in Medical Technology and Health Systems Management, PWU also offers a certificate program in phlebotomy. In nursing and the allied health fields, PWU continues to play an essential role in healthcare education, producing graduates who possess the skills that make them competitive in the country and anywhere in the world.
Ladies and gentlemen, we would like to greet everyone a pleasant afternoon. We thank you for joining us today. NCR and most other provinces are now enjoying alert level 2 with much more freedom to go outside. Yet, you decide to watch us as we bring you the Research Forum 2 in focus, microscopy, and research. Just sit back and learn. We assure you it will be worth your time.
Hello, ladies and gentlemen. This is our second research forum for the year. Unlike the first, wherein we featured the graduate school students and their thesis, today it will be our college students taking the center stage. The School of Medical Technology brings you this webinar with a notable plenary speaker introducing you some methods very useful in experimentation.
Before we begin, let me remind everyone in the virtual room to keep your microphones muted and cameras closed until it's time to use them. I am Kiana Clarice M. Borla.
And I am Astrud Toledo. We are your Masters
We
of
are your
Ceremonies.
Masters of Ceremonies.
In this juncture, Let us spare a moment of silence for the invocation followed by the Philippine National Anthem.
Let us bow our heads and put ourselves in the presence of the Lord. Dear Heavenly Father, we thank you for gathering all of us today. May you bestow your guidance and blessings so that we can enjoy and appreciate its significance in our lives. Bless everyone who are present here today, that each one of us may be able to share our knowledge, understanding, and wisdom for your glory and honor. May the various activities related to this event be a success through your intervention. We all ask of this in the mighty name of Jesus. Amen.
Kayang magiliw, pero saan silanganan? Alam ng puso, sa dibdib mo'y buhay. Lupang hinirang, buyat ka ng magiting. Sa manlulupig, di ka pasisiin. Sa dagat at bundok, sa simoy at sa langit mong bukaw. May dilagang tulad, awit sa paglayang minamahal. Ang kisap ng watawat mo'y tagumpay na nagdidigdig. Ang bituin at araw niya kailan pa may di magdidinig. Lupa ng araw ng at pagsinta mo'y langit sa piling mo. Aming ligaya na pag may mga aming ang mamatay ng dahil sa'yo.
A research forum is not like any other webinars. It has specific aims and presentation. To welcome you all and highlight the objectives of this research forum, ladies and gentlemen, please welcome Professor Sherwin B. Toriano, the Program Chair of the School of Medical Technology.
To our University President, Sir Marco Alfredo Benitez, our Chancellor and Senior Vice President for Academic Affairs, Dr. Felina C. Young, fellow deans and program chairs, administrators, academicians and staff, dear students, to all those watching us today in various social media platforms, ladies and gentlemen, warmest greetings from the Philippine Women's University School of Medical Technology. We are pleased to present the second research forum for 2021 entitled In Focus, Microscopy and Research. This research forum shall highlight the 3 completed thesis research of our college students, which I am proud to announce were all accepted for publication in our research journal. We have invited as plenary speaker an esteemed author of medical technology laboratory manuals, an educator in medicine and med lab science, and also a medical specialist who will elaborate on microscopy, an invaluable tool for experimentation. This virtual event shall consist of a plenary session followed by the thesis presentations. The objectives are: number 1, to elevate the standards of medical technology research theses by enriching the awareness of students, preparing for, and already conducting their studies for a successful and a more contributive study in the field of laboratory science. Secondly, to strengthen collaboration among students, academicians, laboratory practitioners, and other professionals, that they may find a common ground to explore and substantiate knowledge and information by all working together. And lastly, to build a positive and reinvigorating culture of research through the sharing of best practices and relevant experiences. We have conceptualized this event to direct your attention to the use of our primary tool in the laboratory, which is the microscope. It is not just an apparatus to detect, enumerate, and study the morphology of cells in order to complete a procedure. Prior to the advent of clinical laboratories, this tool was used to discover new things, capture dynamic changes, and either to confirm or refute the findings. The microscope is an elegant tool for experiments. As laboratory scientists, we should look at the microscope with passionately gleaming eyes for what wonders it would reveal. And we should repurpose how we use our microscopes, not just for routine testing, but an opportunity to widen our intellectual horizons. Our students highly appreciated technical writing output, and the lecture on the functionality and versatility of the microscope in research brings us to the expediency and the appropriateness of our title, In Focus, Microscopy and Research. So ladies and gentlemen, let us give our undivided attention to the discussions that we may gain significant insights and ideas related to our pursuits in laboratory science and research. Thank you very much, and may you have a stress-free afternoon.
Thank you so much, Sir Toriano. In every endeavor and departmental plans, he is always there to support us. That is why we are very honored that he graced this occasion with an inspirational message. A warm round of applause for our University President, Sir Marco Alfredo Benitez.
Dr. Felina Young, University Chancellor and SVPAA, Mr. Sherwin Toriano, Program Chair of the PW School of Medical Technology, our distinguished speaker, Dr. Frederick Lanera, our dedicated faculty, students who will be presenting the researches, and all our guests watching on our social media platforms. Good afternoon and welcome to the second virtual research forum with the theme, In Focus, Microscopy and Research. Our first virtual research forum, held almost exactly a year ago, delved into the proper conduct of a research project and discussed the process of thesis writing, as well as showcased various thesis presentations from our esteemed professors from the School of Medical Technology. This year's second virtual research forum will highlight several of our student researches conducted during the COVID pandemic, which have been accepted for publication in our very own PW Research Journal, proving that despite the circumstances, it is indeed still possible to conduct quality research worthy of journal publication. Dr. Llanera, for his part as an accomplished educator, researcher, author, and medical professional, will discuss microscopy, or the technical field of using microscopes to view samples and objects that cannot be seen by the unaided eye, as a tool in research. He will also highlight microscopy's relevance in the conduct of research and experimentation. The past 20 months of the pandemic have indeed been challenging, to say the least, particularly in the field of research and experimentation. Access to laboratories, both on and off campus, for the conduct of experimentation for our students have been limited, particularly for students that reside in the provinces or even outside the country. Lab professors have resorted to virtual lab simulations in order to give students the opportunity to witness and partially experience the lab setting. While at times suitable, it is far from ideal. The pandemic has been a test of resilience and creativity on the part of academic research. Nonetheless, I am proud to say that despite this ongoing pandemic, the university has revitalized and strengthened its thrust to promote a research culture across all of our programs and in all levels, from basic education all the way up to graduate studies. Our Research and Development Office, under the guidance of the SVPAA and the Research Director, as well as all of our deans and program chairs, have emphasized the importance of conducting research to further expand the field of knowledge, and more importantly, to ingrain in our students the passion for lifelong learning. In closing, I would like to congratulate the organizers of this research forum, our PW School of Medical Technology, for continuing to uphold and promote this culture of research through fora such as this. Congratulations especially to our MedTech students who will be presenting the research papers today. May this serve as a motivation for your colleagues to also pursue and publish their research projects despite the challenges and limitations they are facing. Thank you very much, and I look forward to a very informative session.
Thank you for that inspirational message, Mr. President. I hope that everyone shall take into the heart of the important points that our President had said. For this second research forum, we opted to focus in microscopy, an indispensable tool in medical technology, not just for the diagnostic testing, but also for research experiments.
After the speaker is through, if you have questions, please type it in our YouTube chat corner and we shall be reading a few on the open forum. And here to introduce our guest speaker is Professor Sherwin B. Toriano, the Program Chair of School of Medical Technology.
Good afternoon once again. Our distinguished speaker is a board of examiner from the Philippine Society of Pathologists. He is also a board reviewer in medicine, medical technology, and specialty board diplomate examination in pathology. He is the founding dean of Onciano College of Medical Technology in Antipolo City and also the ICCT colleges. He is a tenured faculty, assistant professor 3 in the University of Santo Tomas, Medical Technology, and also a borrowed faculty in the UST Faculty of Medicine and Surgery. He is an associate professor 4 at UERM College of Medicine. He is also an assistant professor 5 at De La Salle Medical Health and Sciences Institute. He is a medical specialist 4, chief resident and clinical research fellow in cardiovascular pathology at the Philippine Heart Center for Asia. He is a medical specialist 3, research and innovation office of the Research Institute for Tropical Medicine. And he is also the head of laboratory of the Cainta Municipal Hospital and the CEU Clinical Laboratory. He is the author of C&E laboratory manuals, which is being used nationwide. Ladies and gentlemen, please welcome our guest speaker for this afternoon, Dr. Frederick R. Llanera.
Thank you for that introduction. And with your research outputs of the university, I think that it is very fitting for microscopy to be included as a tool for research. Okay. So we go to the indications for the use of each type of microscope. Okay. So for the indications, we have to examine first the different types of microscopes. So we have, first of all, our bright field or light microscope. Okay, and then we have our phase contrast microscope, our polarizing microscope, the dark field, and the electron microscope. So these are the types of microscopes that we have to be familiar with, especially if we are doing research. And PWU is one of the pillars of master's degree, especially in the field of medical technology. So we have to also have our inclination to use microscopy. And as what Sir said, we have to view it with gleaming eyes and with a different point of view, especially now in this challenging world, know that we have to be always abreast of what the latest are. So the first is our bright field or light microscope, which we are very familiar with. And then the second is our phase contrast microscope. So what is the phase contrast microscope? So in effect, the phase contrast technique employs an optical mechanism to translate minute variations in phase into corresponding changes in amplitude, which can be visualized as differences in image contrast. So one of the major advantages of this is that living cells, like for example platelets, can be examined in their natural state without previously being killed, fixed, and stained. And as a result, the dynamics of ongoing biological processes can be observed and reported in high contrast with sharp clarity of minute specimen detail. Like for example, in our platelets, we have platelet aggregation, adhesion, secretion, they elaborate granules. Okay, we have our alpha granules, our delta granules, our lysosomal or lytic granules. So that's very important. Okay? And then we have our polarizing microscope. So we could use the polarizing microscope in synovial fluid studies. So for example, we want to rule out gout versus pseudo-gout. In gout, we have uric acid crystals. In pseudo-gout, we have calcium pyrophosphate crystals. The diagnosis will differ because the management will differ. So if they present with the clinical features which are similar, it is up to the medtech to release a result which will help the orthopedic surgeon or the rheumatologist in the management. Another is the dark field microscopy. So the dark field microscope is microscopy against a dark background. So we use that for spiral bacteria, Treponema, Borrelia, and Leptospira. And they could be contrasted. If we want to do a study, we could do vis-a-vis serologic testing with patients who have this, and then do dark field microscopy, and then do a metallic impregnation. So in metallic impregnation, the metal like gold or silver can be impregnated in the specimen. So it is a physical, compared to a chemical staining, it's a physical entity which will just overlay the organism. And of course, the most complex will be our electron microscope. So the electron microscope, we have the transmission or TEM and the SEM or the scanning electron microscope. For the transition electron microscope, it will be passing through the different barriers of the cell. But for scanning, it is just a higher view of the surface. And so it's called our scanning electron microscope. Okay. Now, if we go now not to bright field microscopy, so if you could see this one, so we have an example. So histopath is the least favored research topic among BS and MS students. Maybe because the advances in this field are not so much compared to immunology or bacteriology, microbiology. So they are more advanced with regards to their studies. That's why sometimes in journals, the thing is if they are using histopath as your thesis, you might be having journals which are more than 5 years ago. So that's normal because it's not really an field. Now, we could use or experiment on fixatives and stains. If we want to have a substitute for a fixative or a substitute for a routine stain. Like for example, here, what we have in focus now will be the gross and the microscopic. So the gross picture of the appendix, okay, so if you do a histopath section, if it is normal, you will see the different layers with no neutrophilic infiltrates. So we could do, for example, a study on the effect of staining, for example, or the effect of fixative on normal and abnormal slides. So if we compare this with the next one, okay, so in the next slide, we will see that you already have the neutrophilic infiltrates. If we see the entire thickness, so this is comparing the normal on the anatomic right with the abnormal on the anatomic left. So this slide will now comparing in high power the number of infiltrates. So we will see that the infiltrates are studied among the pink layer, that is the muscular layer. Okay. Now, if we have a different specimen, like the sample in the next slide, we're going to see the next specimen, which is a breast tissue. Okay, and then there is the gross examination. If we look at the microscopic examination on the next slide, okay, we will see that on the anatomic right side, we have fibroadenoma. You see that the glands are compressed into slit-like spaces. The covering or the line epithelium will be composed of a bilayer of epithelial and myoepithelial cells. It connotes that they are benign structures compared with the anatomic left side where you have invasive ductal carcinoma. So there's one thing, you could do changes in fixative. You could vary the fixation time, and you could even do immunostains. So for example, you could do in breast cancer, we use ER, PR, and HER2/neu. Okay, these are the advancements in immunochemistry, immunohistochemistry, IHC. So we have ER, estrogen receptor, PR, progesterone receptor, and HER2/neu. So if they are triple negative, that seems to be a problem for our oncologists and surgeons. Okay. So if you use microscopy as a tool in research, next slide. Okay, so the microscopy. So here we could introduce microscopy as a tool in the different subjects or the different backgrounds of the study, objective, significance. So we could always use microscopy as a tool. So this will be the layout of the study, and we could interject microscopy here. And what is important here is in the last heading under methodology, We have ethical research, method analysis in the double-blind study. What is best to do is to have a double-blind study, meaning to say that the principal investigator and the evaluators do not know what is the fixative use or what is the state used to avoid bias. So that is very important so that you come up with a more objective study, you come up with a stronger literature, and you have stronger statistics to back you up. Okay, so next, these are the fields to explore. Okay, the research ideas in tissue processing. So just to give an idea, you might focus on, as what I said earlier, a change in fixative. So, for example, we are already dealing with formalin now. Okay, so formalin is formaldehyde. It's HCHO. So it's an aldehyde. We might use another aldehyde which is non-toxic. The problem with formalin is that it is an ideal fixative. It's cheap, it's readily available, it penetrates the different layers of the tissues, but the main drawback is it's being toxic. It is classified as a carcinogen. And while it is being used worldwide, we see that the laboratory staff might be avoiding this, especially in an air-conditioned or closed area with no adequate ventilation. So the toxicity is day in, day out, especially if they have been in the laboratory for many years. So they might also accumulate in the body and produce toxicities. Another is its foul-smelling odor. So aside from being toxic, it's also foul-smelling, and we do not want to have that. It's sometimes irritating to the respiratory tree. So we could formulate another fixative, because the role of fixation is to arrest the development of lysis, meaning to say that it has to be in a lifelike appearance, that it is somewhat looking like it is still connected to the body. Okay. So aside from that type, we have the additive versus non-additive. What's an example? Additive fixative is like formalin. Non-additive is alcohol. So I mean to say that they either add up to the chemical structure or they do not add up to that structure. They may be strong or weak cross-linkers. So when you have weak cross-linkers, they also have other binding sites in their chemistry, in their chemical structure, so that you could also add other substances. Toxic versus non-toxic fixative. So there might be a non-foul-smelling fixative which is not toxic. Actually, it is already being tried worldwide, because the problem now is that when formalin runs out, which might never occur really, but we should be prepared that there is an alternative. So we have to be, since we have this pandemic right now, so we were not prepared for that. So likewise, in tissue processing, we're not prepared. If something goes wrong, formalin production becomes very scanty. Okay. Now another field in histopath is the stains. Now we could offer special stains. Some would have it from fruits, like for example in dyes or coloring or kasubha or alukbati, or if you have other stains like in when we use this for sauces, for food, we could use it as a stain. Okay, or we could use our immunohistochemical stain. So in the past, the US has already been doing immunohistochemical stains. So just to give you a bird's eye view of the importance of doing an IHC. So there is a mediastinal tumor which will undergo debulking, meaning to say they will have to remove that tumor. Now, when they do tissue processing, the appearance of the slide is that they have all small round blue cells which are monotonous looking. So it's either thymoma or lymphoma. Now, under H&E, okay, we have been using hematoxin and eosin for quite some time, for the last 50 years or so, because hematoxin is good for the nucleus and eosin is good for the cytoplasm, and it's pleasant to the eyes. So there's no problem with reading, with the fatigue of the reader. It's pleasant to the eyes, it blends easily, you have a mixture of pink and violet. Now, the problem is when they are mimicking the same lesion, thymoma versus lymphoma. So immunohistochemical must become antigen. It will thymoma, but it will positive in lymphoma and negative in thymoma, because thymoma is epithelial. Lymphoma is leukocytic in origin. So if you have brownish area because of diaminobenzidine, that is lymphoma and not thymoma. And that is very important because the surgeon will now the oncologist will now have the difference in management because lymphomas are treated by chemo, thymomas are treated by surgery. So imagine the role of histopath in the diagnosis and management of diseases. Okay. So aside from fixatives and stains, okay, so if we, for example, have this length of fixation, okay, for the length of fixation, so if you see here, okay, could we have one slide back? Yeah, so if you see here, no, the one with the two structures, yes. So if you see here, we vary the length of fixation. No, so if you see the right side, no, you'll see that the fibers are parallel to the one on the left side. So the right side, so you see that the pink areas are very well stained, but in the left area, you see that they are lighter because of the length of fixation. So if we want to speed up the turnaround time, the standard time is 24 hours. But of course, there are factors which accelerate fixation, like the thickness of the tissue, the presence of fat, mucus, or blood. Heat will accelerate fixation. That's why sometimes we use microwave technology. So that's one field of study. You can compare microwave technology versus actual fixation. Because in microwave, why is it that if we put our food in the microwave, it becomes hot? Because the oscillating frequency, the movement of molecules will be increased. Now that's when it gets hot. That's clear. Heat accelerates fixation. Okay? So the length of fixation, the type of fixation, is it a liquid fixative or it's microwave technology? Okay. Now in the next slide, okay, so we will see that we could grade structures. So if you see from the anatomic right side, the nuclei are very dark. This actually is placenta. No, these placental tissues, no, and the immature placental tissues would be lined up by cytotrophoblasts and syncytiotrophoblasts, which secrete HCG, human chorionic gonadotropin. That is actually the hormone that we detect in pregnancy tests. So we could use this grading of 0, 1, and 2. So if the nuclei are very seen, it's a grade of 1. And if you just see ghosts or traces or not at all, that is 0. So when we say double blind, the operator or the principal investigator does not know which fixative and what length of time was used. The reader also would not be able to know. So it is very unbiased or really objective when the observer or the investigator or the evaluator will say it's 2, it's 1, and it's 0. We try to narrow down because if the scale is 0 to 10, it might decrease the value of the study. The p-value will also be affected if you have a high scale. So when you are doing the study, you always think of this in mind. The statistics that I will use I use ANOVA, chi-square? Is the sample size adequate so that we have a normal or a Gaussian distribution? Are the p-values at the end of each tail already adequate so that we know that we are doing a statistically representative study? So if you have 0 to 10, that will be very difficult. But if it's just 0, 1, and 2, that will be better. So you narrow down and it's more specific. The statistician will not get mad at you. Okay. So next, in the next slide, we'll now be having our routine stain versus immunostain. Now, when we do sections so that we have a parallel study, you have to have a technique also in microtomy, in the microtome. So after one slide, after one pass, you do another step section. Actually, if there are bulky tumors or tumors that we think will be subjected to immune stain, we already do this one because we know that it will come back with a request for immunostain. So we prepare them, and then we have step serial sections. Because like, for example, this one, in the right side, you have a routine stain. You see that the epithelial layer is very well delineated. Now look at the cytokeratin stain. The cytokeratin will visualize those which are epithelial. So only those which are brown at the lower right corner, you see there that it's brown. So it's the only epithelial area. So the one at the middle, I'm not sure if you can see my pointer. So the one at the middle will not be highlighted there on the other side. So it means that cytokeratin will only line up epithelial layers. It will delineate whether that is epithelial, because epithelial is carcinoma, If it's connective tissue, it is sarcoma. So immunostains will be very useful. That's why we were when I was in residency, I was amazed with how American trained pathologists would really be very better. But that's because from the routine stain, they were able to see the immunostain, so that when they see another case of a routine stain, they are able to predict the diagnosis, because when they were training in the US, they already have the immunostain. And fast forward to 20 years, we are already at par. No, when we are at par before, but because of the advent of the immunostains, the residents are very proficient in interpreting immunostains and correlating which immunostain to request for. Okay, so another slide. Okay, so you have here, I believe this is another step section with only the brown areas are epithelial. No, so the lamina propria, the basement membrane, the muscularis propria are not the ones which are highlighted, only epithelial. So again, we use sections so that when we view them, what will be in the H&E will exactly be what is seen in the immunostain. Okay? The problem is the cost. It is really very costly. That's around 2,000. I think it depends if you have desmin, vimentin, cytokeratin, synaptophysin, chromogranin. It depends, calretinine, HMB45. So these are the immunostains that are run of the mill. In our center, we usually have that 3 times a week because the controls are expensive. So we cannot run it as how it runs its H&E. Okay. So research in the new normal. So next slide. So the research in the new normal. So we have our factors to consider: specimen collection, because the ethics committee are very strict here. So that will also delay your study, okay, if you have specimen collection, because like if you have surgeries, it's difficult to get the consent before surgery. It's also difficult to get it post-op. Okay, so the sample size. So if you are really waiting for a particular sample, okay, and then you have to undergo the technical review, and if it's okay, you go to the ethical review. And if you are dealing with organisms, you have to have the BRMO, biorisk management. And if you are dealing with animals, you have to go to IACUC. Before, it was not really that strict, but we are definitely employed the Helsinki Agreement, wherein there must be consent. So every human sample needs a consent now. And of course, GCP, our good clinical practice. The validity of GCP is around 2 to 3 years. So when you are doing your study, you have to have GCP, and then if you still continue with the study after 2 years, you have to renew the GCP certification. Okay. Now, aside from histopath, if you would also want to use microscopy as a tool, so we have it also in other disciplines. Like in the next slide, we have bacteriology. Okay. So in bacteriology, we could evaluation of substitute culture media. So we know that for a fact that to isolate an organism manually, if you are not using our automated machines, you have to have the appropriate culture media. Okay? So we could perform microscopic evaluation and subsequent confirmatory procedures to augment bacterial identification. That's how important the culture medium is. It provides the nutrition and the environment for the growth of the organism. So another field of study is you use microscopy as a tool if we want to develop a culture medium. Okay? And then we could also use chromogenic agar, because there are those which are you could differentiate the organism by the change in the color of the agar, or a comparison of MICs with automated techniques. Because, for example, if we are using an automated machine, the culture could be there in 4 to 6 hours. Yes, we have automated machines, and they do not only give the sensitivity, intermediate, or resistant range. They give the MICs, which were in most of the infectious disease consultants would be needing that. Example, they have Pseudomonas. They want to. Since in Acinetobacter, these two are multi-drug resistance. That's why they want to use the MIC as their tool. Aside from bacteriology, next slide, we have parasitology. Okay? So it could open another door for you if you want to study on morphologic evaluation. For example, Entamoeba histolytica and Entamoeba dispar can only be discriminated by PCR. only PCR can distinguish dispar and histolytica. So what you could do is, if you are really familiar with that, you could grade microscopy. You could do your evaluation and then run PCR, and then you run it side by side. So in case that is your study, maybe it will be a Pearson statistics, because in Pearson you test the runs versus a gold standard. So perhaps you could do it that way, or you could do it a three-parameter study: microscopy versus immunoassay versus PCR. Okay. So there are a lot of fields of research which would really involve microscopy. Okay. You cannot do without that. Epidemiologic data, for example, common in a locality. For example, here we have the ring form of Plasmodium vivax. Why? Because it is larger. The infected RBC is larger than the rest. So you think of vivax or ovale, but the most common worldwide is vivax. Usually here in our setting, we usually have vivax and falciparum. Okay? So ovale is not usually seen. Okay? So what is predominant here would be our Plasmodium falciparum and vivax. Okay? Now another field is hematology. Next slide. So in hematology, we could do peripheral smear versus cytochemical stains. So this is one avenue where I think you would also be interested in for those who are pursuing their MS. So just hang on, because it takes quite a while. But if you really persevere, or if you're really interested in that field of study, you would be completing your study in no time. Okay? So in hematology, we could compare peripheral smear versus cytochemical stains. Like, for example, in distinguishing an AML or ALL. So if you have sample size, when you have a clinic where you deal with peripheral smears with abnormal cells, maybe you can check for the peripheral smears. If you see blast cells or left shift to the left, you could commit on this one. Is it a myeloblast or a lymphoblast? Okay, and then you compare with the cytochemical stain. You send it out, and then you commit first before you do your other side of the study, which is cytochemical stain. So morphologically, you could commit. If it's a myeloblast, it's AML. Lymphoblast, it's ALL. So in size, the myeloblast is 3 to 5 times the size of a lymphocyte. The lymphoblast is only 2 to 3 times. So myeloblasts are larger. The nucleoli are more prominent in myeloblasts, and the amount of the cytoplasm, moderate gray, for myelo, and for lympho, it is scant blue. Our rods are a bonus, so that means it's a myeloblast. But they can only be confirmed by cytochemical stains, because L2 is AML-like, which means that if you do your cytochemical stains, what will be positive for myeloblasts will be Sudan block B and myeloperoxidase. Now that means that if you have myeloperoxidase, the first to become functional is its phagocytic aspect. Okay? So you could do peripheral smear versus cytochemical stains. Okay? So another field of study is in blood banking. Okay? So in blood banking, you could have ABO discrepancies. We could use our ABO discrepancies if we have the gel or the bead. Okay, so next slide. So here we have our gel technique. So you either use a gel or a bead, okay, in having our ABO discrepancy. So one thing in microscopy is that you could resolve it by you doing saline replacement. So in the last decantation, after you remove the serum, you replace it with saline, so that you could delineate if it is agglutination or rouleau formation. Okay, so we could use this study. Okay, so agglutination versus bead and gel. Okay, so that is one thing. So you could do microscopy. The role of microscopy here is to evaluate first using that technique, forward and backward type, and then compare it with gel or bead technology. Okay, you could also use this for transfusion reaction investigation, okay, and antibody screening. Okay. Now another thing, okay, here, okay, is in our clinical microscopy. Okay, next slide. So in our clinical microscopy, also we could use our tripartite or our trifold discrepancies. Or for example, if you are doing microscopic evaluation versus urine flow cytometry and imaging techniques. So for microscopic evaluation, we could already commit, if you saw these crystals or this gas, and then you go into urine flow cytometry, and then there's another piece of the machine wherein it has pictures already, and they will compare. For example, you saw a cast, or you saw trichomonas or any other structure. It has some sort of a photo album where you could compare it with that one. So again, this will be using three parameters with microscopy. Okay, the microscopy. Okay. So next, in stool examination. Okay, stool exam. Next slide. So for stool exam, you could also have morphologic differences among eggs. No? So for example, here we have our hookworm or Ascaris, okay, and Artemia. So we have sample preparation plus scanning plus analysis. So we could compare this, for example, with a reference. So same principle as what we have in urine. So if you go over the different sections of the lab, microscopy is one common theme. Okay? So next slide. So as a tool, okay, so we could exploit the possibilities of having, next slide, so of having all of the different types of microscopies. What we have said earlier are electron microscope, but the transmission electron and scanning electron microscope are phase contrasts with different phases, and our dark field microscopy, if we want to compare serology versus visualization, or we could combine the methods. Okay, so there are some 5-header microscopes where you could connect with a projector or a TV to enhance the viewing. Okay. So I think so with those tools, microscopy is common for all sections of the lab. So if you have research methods, you could always use them as a tool for objective differentiation. If you have a double-blind study, if both the principal investigator and those who are going to evaluate this are also blinded, so to avoid bias. Okay? So we go over the statistics, we go over the p-values, if the sample size is adequate to have a normal distribution curve, a Gaussian curve, if we want to have H or H1 to you have to work with the statistician also, so that you are guided. Always work with the IERB so that you could have periodic updates in your study. And you have to always consult with your advisor. And if you already have a colloquium, the colloquium is a very important tool because during the colloquium, you will be able to have a run-through with your panelists. And you do the colloquium if you already are done with 70 to 75% of your study, so that when you go to the defense, it will be smooth. Because if you do the colloquium outside, for example, and you have a presentation in a convention, in a webinar or seminar, chances are your panelists would not be able to gauge that. So if it's the first time that you're going to see your panelists on the defense day, you might have a major revision. So go over with your advisor, and then go over with the panelists so that all of the three, so if it's an MS, it's 3, it's dissertation, it's 5. So you'll go over with them so that when you're already able not to correct the major or minor revisions, when you go to the final defense, so that will already be smooth because you will just be given 15 minutes for an MS and 30 minutes for a PhD for you to defend your thesis or dissertation. So you only the essential parts of the study. So always practice with the oral defense. And of course, you have to be always prepared with the question answer after. Okay. So I think that is the role of microscopy as an avenue or a tool for research and how it will be applied now when you go to your MS already. Okay. So thank you. Thank you.
Thank you very much, Dr. Lianera. There are some questions from our students and professors. Let us begin with Professor Sherwin Toriano.
Thank you very much. So, Dr. Llanera, you have given us a wide range actually of topics to choose from if we are to pursue microscopy for our thesis or our research. I myself had my thesis as with having microscopy as a topic. It is parasitologic, And of course, mixed with histopathology, wherein we were able to check the effect of the inoculum on the intestines of mice. Now, some of our students, particularly in masteral theses, are asking if you are to ask for paraffin blocks in the hospital, how long is the storage that would be allowable for it to be able to be given out when asked for a thesis study? So for example, if we are to ask for the paraffin blocks in the hospital, so can we give out as early as 3 months storage, or do we require a 6 month storage first before they can be released? If the tests were done months ago and we are to use the paraffin blocks for the thesis, would it require an ethical board approval?
Actually, like in any other field of study, so for example, with those involving specimens, so human specimens, so you have to, for example, one is a GCP certificate, so that your good clinical practice would be there, and embodied in the GCP is the consent. So you have to have a, if you are going to seek for IRB approval, you have to submit first the research proposal to the hospital's technical and ethical review. In some hospitals, they do not have a technical, the IRB, because in some, the dictum is that if it is not ethical, it is not technical. So in some centers, there's a technical and ethical review. In some centers, it's only the ethical review. So if you are done with, they might seek a co-author from the hospital, because the problem there is the intellectual property. Because if you are will using the samples of that institution, they have to be mentioned, and the IRB as well as the director of the institution must be aware of that. So if they have a protocol or they have a rule on that, you have to pass through that. So it has to pass through the department head or the division head of lab, and then go to the IRB. And sometimes they have an amount to pay, and then aside from that is the consent, because if it is retrospective study or chart review, the more that we need to have a consent for that. So the IRB would be an invaluable tool. So they will you will have to pass through that, because they have to get approval of that. And sometimes if the specimens are crucial and the management of the patient is not yet done, they might have they might use the records in the archives of the Philippines recommend 15 years before they dispose of records. But now we already have high-speed scanners in most where they have to scan. They destroy it physically, but they have electronic copy. So you have to pass. So I think the first step is that you pass through you write a letter to the lab or to where that section is. For example, a pulmonary, cardiacs, or renal dialysis or what, or perfusion. And then if the head says okay, it will be forwarded to IRB and then to the director for final disposition, because they might need a co-author in the hospital, or the question is the intellectual property and the consent. So those are the variables. It's a little bit more challenging now than if you did your MS maybe 20 years ago, because now we are bound with the Helsinki document, and we have a lot in social media, so there might be issues of plagiarism or using data of another. So we have to be very conscious with that, unlike before.
Also, that would be a retrospective study, doc, when we are using the results of the hospital. But what if our student would want to have the paraffin blocks because they would want to cut portions of it for a newer staining method, for example? So how long, or yes, how many months would the paraffin block be allowable so that they would be released by the hospital? If, for example, the student would have a
So again,
they would agree.
Yeah. So I think the first step is really to have the consent and the IRB approval, because that will take, in some institutions they meet twice a month, every Wednesday, for example, like that, every Wednesday afternoon. So they will deck that to an IRB, and they will go over that study. So it depends. For the months, we cannot actually kasi for example, if you are using, for example, in the example paraffin black, kasi when you the paraffin black is really essential because if you do recuts, so sometimes the lesion becomes thinner and the lesion is no longer there. So if you want to get a second opinion, so parang it will be difficult for the patient or the surgeon to, because for example in our case, no, we cannot just give out paraffin blocks because sometimes the surgeon would go back that I would like to have the second opinion to another oncologist, and then we don't have the block anymore. So parang pagalitan kami. So parang I think ano ba? I think that's the first step. No, so we write a letter to to IR, to the department, to lab, for example, in our case, the head of our lab, and then to IRB for properties. And yun nga, sometimes they need a co-author. They need a co-author because the
Okay.
property, doing my thesis, ganun din kasi.
Okay, thank you very much, Doc. I think the MCs also have other questions. Our MC, you may ask questions now on your end.
Yes, for the next question. Masteral students in MSMT are required for experimental studies. If they are to pursue cytologic urine studies with interventions, what would be your advice?
Okay. So urine, so one thing is that urine is readily available. So it is not through venipuncture. It would employ less pain for the subject. So I think the first step that they have to do is what in urine cytology they would like. So I think if they would like to compare it with a parameter, for example, in urine, the reason for doing urine cytology perhaps is if you want to detect bladder carcinoma, so urinary bladder carcinoma. So I think you see, you get smokers because usually urinary bladder cancer is associated with smoking. So you get chronic smokers, diagnosed cases, and normal cases. So what is in their urine cytology that is different? And we want to make it more interesting. What is a parameter in urinalysis which will be an initial clue in the development of urine CA, of bladder CA? So that would be, kasi when you think of a study, you always bear in mind what is its advancement in science. That's why before the research advice, before you are given a go signal for your topic, the first question is that, will this bring advancement to science? Because of course you will not study effect of smoking on lung cancer because we already know that. So the basic thing is there a contribution to science? What is its contribution? That may be one of the uh, questions by your panelists or even by your research advisor or even yourself. Is there a contribution to science? Will it bridge a gap between this one that we know and this one that we already and this one that we want to find out? If it does bridge the gap. So for your urine cytology, maybe my advice is to focus maybe on a gene. If you on a gene, or you could do PCR with that gene and exploit that possibility, or is it common in because bladder and renal cancer is it runs in the family. I know of one who has painless hematuria. His uncle had that, and then when we had this episode, automatic ultrasound, and then renal cancer, they had to do nephrectomy. So siguro, I think one advice is to get a clinic where you have a lot of sample size, because that is the first step. If you do not have sample size, you will not have nothing. You will have nothing to work with. So one sample size. Second, what would you like to study in particular, and then dwell on that. And then if they are look at the journals, because the statistician will check how many do you need to have a statistically significant study with a p-value of 0.05. If there are none, the statistician will always say, do 5 trials, and then from that, will compute the sample size. Sometimes they have SSPS, the Statistical Package for Social Sciences, so they enter into that software, and then from that, they will be knowing what statistical tool to use and how many sample size is needed. Yeah.
Thank you for that, Dr. Yanera. For our next question po, how are we to compensate in our online classes topics about microscopy? And is LF2F imperative in the successful microscopy practice?
That's a very nice question, no? Because if we are doing online, so I think it is not a deterrent, or let's not make it well, it is challenging, but let us not make it the end point, meaning to say that the other years will be better than me because they had microscopy, actual microscopy, and then for me, it's just this one. So, granting that that is really the problem that we have, that we are really facing right now, we have to double our effort. So since we compensate, we can compensate because there are digital images already. So if you want to be abreast with microscopy, so the next thing that you have to do, if we are still in this situation, is that you have to go over images. Even there are textbooks which are already online, so it must not be a deterrent. It must pose as a positive challenge, so that we work hard. Because the secret in microscopy is to be familiar with the structures. Like for example, in histopath, how are we able to differentiate the lecture versus invasive ductal carcinoma? So you have to know, first of all, normal tissues histology. You will not be able to determine abnormal tissues if you do not know histology. And then second, always become familiar with it. So for example, in our hema blood cells, always be familiar with the normal, so that when you see something abnormal, at least you know when to refer. So at least at the point of level of interns and students, if you see something abnormal, at least you know when to refer. Because if you are differentiating, for example, red cell series, metarubricite, rubricite, prorubricite, rubiblast, or myeloblast, promyelocyte, myelocyte, metamyelocyte, it takes years. No, it takes years for that. But at least you know normal versus abnormal. If you do not have actual microscopy, there will come a time that you will have actual microscopy, but you supplement with images. So you go over pictures, you go over with them detail by detail. So for example, if you're familiar with that, you will not be mistaken. So for example, you see a dog, you might not know if it's a poodle or German shepherd, but you know it's a dog. So that's the basic step. You know it's not a cat because you have features, you have criteria. Even parasitology, for example, the eggs of the parasites, the blood cells, okay, the agglutination, flocculation, these things. So even if we are in a challenging time in our lives, it's the first time that it happened, of course, we have to be more interested. So let's compensate by augmenting what technology that we have. So lucky that we have new technology. It might not compensate really, but it will be a help. Then when we are already transforming to the normal, we could cope up. We could do some extra work for that. But let's not make the pandemic a reason why we will not be good medtechs.
Yes, and for our last question, Dr. Llanera, how accurate is the urine sediment microscopy done by automated urine analyzers as compared to manual microscopy?
Okay. Uh, there are two principles in. Okay. So first, no, and in microscopy, when Joseph and Wallace Coulter uh, did studies on Coulter counter. No, that's why Coulter is the name of the Joseph and Wallace Coulter. So they said that cells could be lined up in an aperture, and they could be counted and classified. And most of them did not believe them. But 50 years after, look at what happened. Flow cytometry is being used right and left. Light scatter. No, we have different machines. There are those which use a forward scatter, 0-degree scatter to determine cell size, and orthogonal 90-degree scatter to determine internal complexity and granularity. So it's now being used left and right. Multiple angle, 10 degrees, 15 degrees, they use that also. We have been doing that left and right now. Now, come forward to the fast forward rather to urine. They said it could not be done, but now it's being done. Okay, so it's very accurate, the one that we use now. And before, when we have our analysis, for example, microscopic, no. So for example, past cells 2 to 3, RBC 3 to 4. But now the machine reports the exact number 205, 308. So that is more accurate. And there is a factor, if you want to, let's times 13.1. If you want to convert for example, 408 passettes, how many is that in per high power field? There is already a conversion for that. So it is more accurate, no, for flow sci. The intermediate machine is that they have images. The principle with that machine is there is an album. It's like a photo album. So for example, like a Mona Lisa. So that's already saved in that slide. So when you encounter it there, they will choose. It's like the prisoners being lined up, and the one who will point out who is the prisoner there. So it's like that. So there are two principles in urine automation flow sci, like in blood, and the one wherein imaging is the principle. So I think how accurate with our results, we tried to run not a formal study, but we just tried to run randomly a normal abnormal, and then it is doing great now here in our center. Okay. So I think it's my urine microscopy is accurate.
Thank you for that po, Dr. Linera. For our last question po from Dr. Lim, in research using immunohistochemical staining, what are the usual equipment needed to be able to perform it, and what are the uses of immunohistochemical staining?
Hi, Dr. Lim. Nice to see. Nice to hear from you. Yeah. Okay. In research using IHC, the usual equipment, hindi kasi abot ito doon. Walang Wi-Fi sa kabila, no? Pero the histopath is just down there. But we have a microwave oven, and actually, during my this time, there was no IHC, no? But because of this technology that we need to confirm, like what I said earlier, no, that we use IHC, for example, in the thymoma burst lymphoma. Okay, it's very important, no? Especially that we are always have mediastinal tumors being at the center where you have that as a specialty. Not only there, no, in a lot of lesions, we use really IHC as a method of confirming H&E. So the equipment used, we have a microwave. No, it's a microwave, and we have our passive and negative automatic pipetter. So when you load it at around 7 a.m., you're done by 2 to 3 p.m. That's why before, when we just used to evaluate, when we just say, ay, hindi maganda tong slide na to, but it hurts for the medtech, no? So parang nung ako nag-run, para sa ko, wala magsasabi na pangit yan. Because it takes so much time and effort and expertise to do it, and then in 10 seconds, you're just going to judge it. So that's how, so when I did the running, so that's how I learned na ganun pala siya kahirap, tapos sasabihin lang after 10 seconds, hindi maganda. No? Pero if you do it regularly, siguro mga 6 hours, kasi there is an antigen retrieval step. Okay, that's why you could use paraffin embedded tissues, blocks, no, as an agent for IHC also. You have to do antigen retrieval, and then you have your microwave, and then you do the antigen capture using an epitope, and you label this one also. So there is a conjugate and a buffer. And after that, you have you have the coloring agent. It's called DAB, diaminobenzidine. That is the reason why IHC will turn brown because of diaminobenzidine. So there are two epitopes which will land on that structure, on that platform, and that is how we utilize that. So sometimes it is the presence of the brown or DAB which is needed. Sometimes it is the absence. For example, in prostate cancer, in prostate, you have a bilayer. So if you see 2 layers, it's benign. If you only have the downward layer and you don't have the basal layer, that is not good. No? So we usually have to have the KI67. There's a special state also for that. So there are a lot of uses of IHC. It's a bit expensive. It's around 2,000 per slide. No? And because the controls also, you have to run it with a passive control and a negative control. Cancer, negative sa ER, PR, and HER2 because if you are positive, you're usually given oral tamoxifen, and patients live very long. They live healthy, they live very long because of the oral tamoxifen, as oral chemotherapy. So IHC is here to stay. It has evolved from 2 to 3 immunostains to a vast. No, we offer over 50 plus immunostains: calretinine, cynatamicin, chromogranin, HMB45, okay, KI67 for adenocarcinoma, FLAP, CD15, CD30. Marami. So IH is here to stay, and it helps. Okay, thanks.
Again, thank you so much, Dr. Llanera. Moving forward, may I call on Sir Sherwin Toriano, the Program Chair of the PWU School of Medical Technology, to present the certificate.
Thank you very much, Dr. Llanera. So I am happy to announce that Dr. Llanera is our newest addition to our faculty in the School of Medical Technology, particularly in the graduate school. So let me read the citation. The Philippine Women's University School of Medical Technology presents this certificate of appreciation to Dr. Frederick R. Llanera, our guest speaker for today, for imparting invaluable knowledge in the Research Forum 2, titled In Focus, Microscopy and Research, conducted on the 18th day of November 2021. Again, thank you very much, Dr. Llanera, and congratulations.
Hi, thank you, sir. Thank you.
And now, we shall be entertained by one of our fellow medtech students with a song. Let's warmly welcome Mark Starneches with a big round of virtual applause.
Thank you for that performance, Mark. Let us now come to the second portion of the show, the student research. We have three groups of presenters. Group 1 is composed of Ms. Rania Maulana, Ms. Shannon Marie Dominga, Ms. Andrea Kate Legaspi, and Ms. Veronica Jean Malay. And here they are. Let us welcome them in.
To our guest speaker, Dr. Leonera, Faculty of Medical Technology, my fellow students, and to all the viewers in the virtual stage, a pleasant day to all. It is my great pleasure to present our research study with Ms. Shannon Marie Dominia, Andrea K. Legaspi, and Ms. Veronica Jean Malay entitled COVID-19 Vaccine Preference as Basis for Vaccination, a Multi-Criteria Analysis. In the next 20 minutes, we are going to discuss the important components of our research study. Now it is reasonable to wonder why we have chosen this particular topic to discuss, and here is the answer. According to statistics, the Philippines ranked third lowest among 21 states surveyed in terms of COVID-19 vaccination willingness, with only 56% of Filipino respondents agreeing to get vaccinated. Yes, approximately 56% of Filipinos are concerned about immunization. So consider the following scenario. If you believe the vaccination is unsafe, under what conditions would you consider vaccine safety to be appropriate? To put it another way, how long would it have taken you to be concerned about its safety? A year, 2 years, a decade? Hence, the goal of our research is to determine if respondents prefer a particular COVID-19 vaccine based on its attributes, as well as to determine how attributes of each vaccine influence respondents' preferences.
In line with the stated goals, this study aims to assess preferences based on the attributes of each vaccine that may influence the response of selected citizens of the province of Cavite in their decision to get vaccinated. It aims to answer the following questions in particular. 1. What is the demographic profile of the respondents in terms of age, educational attainment, gender, health condition, marital status, occupation, residence, and acquired knowledge about vaccines. Number 2. What are the vaccine brands that the respondents are most aware of? Number 3. What is the most preferred attributes of the respondents in terms of manufacturer, side effects, efficacy rate, long-term immunity, and safety? Number 4. Are the respondents willing to be vaccinated against COVID-19? Number 5. Is there a significant relationship between the respondents' preferences in terms of willingness to be vaccinated and their selected COVID-19 vaccines that they are most aware of? And number 6, is there a significant relationship between selected demographic profile and their preferences in terms of most preferred attribute and willingness to be vaccinated?
For the research locale, the gathered data obtained from 151 respondents residing in selected cities of the province of Cavite, Philippines, particularly in Bacoor, Las Marinas, Imus, Silang, and Tanza, via utilization of an online survey questionnaire during May 26 to 29, 2021.
In addition to this, the results of the study will be of great benefit, especially to the vaccine recipients, manufacturers, healthcare workers, government, community, parents, teachers, medical technology students, and lastly, the future researchers.
The study's paradigm depicts the respondent's profile and preferred COVID-19 vaccine attribute being used as a basis for COVID-19 vaccination. As independent variables in the conceptual framework, the study examined the demographic profile of the respondents and the vaccine brands that they are aware of. The respondents preferred COVID-19 vaccine attributes and also the willingness to be vaccinated are the dependent variables. On the other hand, we used an online survey questionnaire as what has been mentioned earlier in Google Forms, wherein we then encoded the data matrix in SPSS and analyzed the data using a chi-square test. The paradigm of the study shows the respondents' profile and most preferred COVID-19 vaccine attribute to be processed as a basis for COVID-19 vaccination. Following this line of thought, if the respondents succeed in answering the online survey questionnaire, it will serve as an output to determine if there is a significant relationship between respondents' willingness to be vaccinated and the vaccine bans that they are aware of. Lastly, the feedback will serve as a foundation wherein all inquiries in the input will be answered.
After the previous discussion of the conceptual framework, the study utilized with, we now go to the actual methodological approach the researchers used. For the methodology, this study utilized a descriptive and correlational research design. Non-probability sampling, specifically convenience sampling, was used as the sampling technique. Similarly, the research instrument used is an online survey questionnaire using the Google Forms platform. The questionnaire was created by the researchers and then validated and confirmed using qualitative and quantitative approaches. For the data gathering procedure, the researchers first received consent from the research advisor and the department's program chair. Likewise, letters written to the mayors of 5 municipalities included in this study were also sent. The validity and reliability of the questionnaire were then tested using the Cronbach Alpha. Cronbach Alpha is an objective approach for assessing internal consistency. A Cronbach Alpha value is 0.842, indicating that the questionnaire is reliable. The questionnaire was then subsequently delivered to the selected respondents using Facebook Messenger. And lastly, the researchers retrieved the data for tabulation, presentation, and interpretation. This is done using statistical tools like Microsoft Excel and statistical package for social science.
Moving on with the result and discussion part of our study, we have here statement of the problem number 1, and it is all about the demographic profiles of the respondents, limited only to age, educational attainment, sex, presence of comorbidities, marital status, occupation, residence, and their acquired knowledge about the COVID-19 vaccine. First of all, most of the respondents in our study are between 18 to 24 years old, accounting for 70.86% of the total. In terms of educational attainment, 49.7% of all respondents are still in their undergraduate years. For the gender distribution, most respondents of this study are female, accounting for more than half of the total. Then for the presence of comorbidities, 78.8% of the respondents appeared to have no diseases or any illnesses. In terms of the distribution of respondents according to marital status and occupation, most of them are single and still a student. Additionally, most of the respondents of this study resided in the city of Bacoor, which accounts for 52% of the total. And lastly, the majority of the respondents acquired their knowledge about COVID-19 vaccines via different social media platforms.
Moving on, this table presents respondents' awareness in COVID-19 vaccine brands. This revealed that Pfizer BioNTech was chosen by 81 or 53.64% of the respondents. This is followed by AstraZeneca, which is known by 29.47%, and Moderna,
with 9.93% of the total respondents. Others specified the vaccine that they are aware of, with 7.96% for the Sinovac Coronavac and J&J Johnson COVID-19 vaccine. In terms of their preferred COVID-19 vaccine attributes, safety is the most preferred, with a mean of 4.65. This shows that people want to be sure that any vaccine is proven safe before getting fully vaccinated. This finding is consistent with the study conducted by Borriello, Master, Pellegrini, and Rose in 2021. Their study showed that vaccine safety has a significant impact on vaccine preferences of their respondents.
The table shows the respondents' willingness to be vaccinated, and as can be seen, 74.83% of the total respondents were willing to get vaccinated. However, only 3.31% of the total respondents refused vaccinations, while 21.85% were uncertain. The table shows the relationship between the respondents' willingness to get vaccinated and the vaccine to be administered. The results showed a p-value of 0.0482, which was less than the level of significance, indicating that the null hypothesis was rejected. This implies that if given a choice of vaccines, people are willing to be vaccinated.
On the other hand, we found that the demographic profile of respondents in terms of age, sex, and marital status had no significant relationship with the respondents' most preferred attribute, which is safety. The findings suggest that the COVID-19 vaccine administered by the government program in the community should be beneficial to people's safety regardless of their age, sex, or marital status. Out of all the other factors, Carlson et al. In 2021 also found that the confidence in the proposed vaccine safety was the most important predictor of COVID-19 vaccination intentions. Finally, there was no significant relation between age, sex, or marital status and respondents' willingness to be vaccinated against COVID-19. Now, in here, it implies that regardless of their demographic profile, respondents were willing to be vaccinated against COVID-19.
We are hopeful that the results presented will be able to contribute to the increased vaccine acceptance, as it will help determine the preferences of the Filipinos, particularly the Caviteños, towards the current COVID-19 vaccination. This gives them a chance to be understood by the government and health officials, wherein they will become more aware of the factors or attributes that contribute to the people's intent to be vaccinated.
Now, based on the above findings of this study, the following conclusion was drawn. First, Pfizer-BioNTech was the vaccine brand the respondents were most aware of. Second, among other attributes mentioned, safety is the most preferred attribute of the respondents. Third, most of the respondents of this study are willing to be vaccinated. Then, for relationship assessment, first, there is a significant relationship between respondents' preferred COVID-19 vaccine and willingness to be vaccinated. And lastly, there is no significant relationship between respondents' selected demographic profile and their preferences in terms of attributes and willingness to be vaccinated.
Lastly, in the light of the findings and conclusions of this study, the following recommendations are suggested. First, newspaper companies may enhance their way of informing the public about COVID-19 vaccines. Second, if the COVID-19 pandemic is already over, dissemination of questionnaires can be done in a face-to-face basis with interviews afterwards. And lastly, future researchers may utilize this study to test it on a wider population using a probability sampling approach, as well as to look into more factors to correlate with.
Overall, others will see that attributes of COVID-19 vaccines are of equal importance, and as such, willingness to be vaccinated cannot work well without assuring that these attributes are well prioritized in formulating a vaccine. To conclude our presentation, we would like to emphasize the importance of prioritizing all attributes as this will ensure that the benefits of vaccination greatly outweigh the risks. If you have any questions, we'd be more than happy to answer them. Thank you very much.
Thank you very much, Group 1. So we are now moving forward for the Group 2 presenters. We'll elaborate about antioxidant food supplements as immunity enhancers. Group 2 is represented by Ms. Felina de Guzman, Ms. Angelica Mendaros, Mr. Carl Mark Simangan, and Ms. Iwon Jibad. The stage is now yours. Take it away.
Good afternoon, everyone. Thank you again for giving us the opportunity to speak here. Our thesis is entitled Antioxidant Food Supplements as Immunity Enhancers Against COVID-19, a Systematic Review. Next slide, please. Here is a brief overview or outline of our discussion. As you can see, next slide, please.
COVID-19 is a disease caused by SARS-CoV-2, which triggered a global pandemic and continues to pose a serious threat to people. And its pathogenesis is complicated and it involves subduing the host's innate, immune, and antiviral response. Next slide, please. So despite the strict measures executed by the government, the country remains under Code Red Sublevel 2 on the Code Alert System, revealing ongoing local virus transmission with greater numbers of cases than the government can address. It is also expected that vaccination of the planet's population will take more than a year to be accomplished. Hence, the focus must be shifted to alternatives such as taking antioxidant food supplements that are approved to enhance an individual's immunity and may be used to mitigate the effect of the COVID-19 disease.
Our study aims to assess the current literature regarding the utilization of antioxidant food supplements through a systematic review. So we, the researchers, seek to find answers to the following questions, such as first, what are the food supplements that are potentially effective against COVID-19 infection? Second, what are the mechanisms by which food supplements can enhance a person's immunity against COVID-19? And lastly, what are the recommendations for the safe and effective use of these supplements in regards to the person's health and age and health status?
So this study will benefit the following individuals, medical technologists, and other health workers, teachers, students, and future researchers.
Springer, Science Direct, iTech Open, Multidisciplinary Digital Publishing Institute, and PubMed were used to perform a comprehensive and systematic search for literature and studies. The researchers also searched for available sources from DOST Science and Technology Information Institute Library, DOST Food and Nutrition Research Institute, and Department of Health in the Philippines.
For the conceptual framework, the input in the framework is the existing knowledge in literature that food supplements with antioxidants have been used against viral illnesses, with identification of the following problems, insight as to which antioxidant food supplements can be used to enhance against immunity against COVID-19, pooled evidence on the effects of different antioxidant food supplements, and discussion as to how food supplements enhance immunity against COVID-19. The activities that will be involved in solving the problems include literature review, establishment of inclusion and exclusion criteria, data extraction, and study of quality assessment. The activities will lead to outputs told through narrative and tabular presentations. Finally, these outputs are expected to lead to the identification of antioxidant food supplements capable of enhancing immunity against COVID-19, generation of recommendations, and encouragement of future research. It can also add to the existing knowledge in food supplements against viral illnesses in literature.
In order to find answers to the research questions, the researchers utilize a descriptive design method in order to assess the components, characteristics, mechanisms, and effect of antioxidant food supplements on the immune system and to describe how those factors can enhance an individual's immunity against COVID-19.
For the searching strategy, the researchers performed a comprehensive and systematic search for literature and studies starting April 19, 2021, in databases including Springer, Science Direct, iTech Open, Multidisciplinary Digital Publishing Institute, and PubMed. The studies included must be published starting 2015. We also search available sources from the OST Science and Technology Information Institute Library, the OST Food and Nutrition Research Institute, and the Department of Health. Moreover, all the citations were imported into Microsoft SL and duplicates were removed.
The researchers also created some inclusion criteria that must be met by the studies in order to be considered acceptable for data extraction. The studies must be randomized controlled trials in humans, and viral respiratory infections will also be observed and discussed. Participants must be consenting children and patients, that is either male or female, and that are at least 3 years of age. Next slide, please. Lastly, food supplements with antioxidants must be used as an intervention and immunological parameters will also be evaluated. And as for the statistical analysis, the treatment and control groups results for interleukin 6 and tumor necrosis factor alpha must be expressed in pg per ml. And moreover, English must be the main language, and the researchers also excluded studies that were conducted on HIV and pregnant patients as well as on infants and the toddlers.
For extracting data, those articles and studies that passed the criteria that were set by the researchers underwent procedures and steps. The researchers had a total of 77 retrieved studies and articles from both databases and other resources. After a thorough screening with regards to criteria and eligibility, the researchers included 20 studies for the qualitative synthesis and a total of 6 studies for the statistical analysis. The data extraction form includes information about the reference, namely the first author, the year, and the journal citation. It also contains some specifics such as the study setting and study design type, as well as the study population, sample size, study duration, interventions, and outcomes. All of the information gathered were summarized in the tables. A1, please.
So the researcher also used the JIDA scoring of the Oxford quality scoring system to assess the quality of risk of bias, which consists of 3 items: randomization, which rate from 0 to 2 point, blinding, which rate from 0 to 2 point, and dropout and withdrawal, which rate from 0 to 1 point. The final score ranges from 0 to 5 point, which with higher score indicating better reporting. So the studies with a JITA score of 2 or less are considered to have low quality, while those with JITA score of 3 or more are considered to have high quality or low risk of bias.
We use a qualitative synthesis to analyze the data. We use an interpretive review form of qualitative synthesis in particular, which involves data interpretations and new conceptual understandings that can lead to the development of a theory that will explain and integrate the concepts of our study. We also use a statistical analysis of the t-test for unequal variances to see if there was a significant difference between the treatment and the control groups in terms of suppression of the two most important pro-inflammatory cytokines, the IL-6 and TNF-alpha, and the relationships to the individual's immunity during COVID-19 infection.
We also analyzed, by the way, the quality of each study through JADED scoring. 3 studies were reportedly of low quality, while another 3 scored high. The rest of the studies have moderately methodological qualities. Moving on to the findings.
So after analyzing the gathered findings, we found out that in the only study which utilized vitamin C alone, the findings revealed that high-dose intravenous vitamin C did not improve the number of invasive mechanical ventilation free days in critically sick COVID patients over the course of 28 days. So for the vitamin D, Aloha, Islam, and Mikhail 2019 found no difference in the occurrence of acute respiratory infections among healthy American black women in the treatment and control groups. Moreover, study of Loeb et al. Also claimed that the incidence of influenza was not reduced. However, the vitamin D supplementation can moderately reduce non-influenza respiratory viral infection. And the remaining three studies focusing on the utilization of vitamin D showed benefits, although Miralay stated that vitamin D did not have any effect on the CRP levels in the treatment group in comparison with the control group. As for the virgin coconut oil's result, it exhibited a significant decline in the mean C-reactive protein level compared to the occurrence of a cytokine storm due to COVID-19 infection after 28 days. And that was according to the study of Angeles Agdepa. Interestingly, all curcumin studies showed effectiveness against viral illnesses, while that of selenium demonstrated the need for longer supplementation. Those who received selenium for 10 days had no significant effects as compared to another study's treatment group, which received selenium for 14 days and exhibited results such as restored lungs antioxidant capacity, controlled inflammatory responses, and significantly improved breathing mechanics. Comparing the two selenium studies gathered, 10 days of supplementation showed no significant effect, while 14 days of supplementation of selenium resulted in modulation of inflammatory responses. Moreover, magnesium supplementation was posited to have no significant effect on its participants. Supplements incorporating a variety of antioxidant components, especially those incorporating more than three components, are efficacious than those incorporating a lower number of antioxidant combinations.
Next slide, please. For the mechanism, three separate studies claim that interleukin 6 and tumor necrosis factor alpha are more highlighted in the period of COVID-19 and suggested that the increased amounts are related to worsening the symptoms and progressing of the disease on to critical stage. Hence, the researchers choose to also focus on the suppression of the interleukin 6 and tumor necrosis alpha. Amongst the gathered studies, curcumin and selenium show significant effects on the suppression of interleukin 6, and while tumor necrosis alpha may be suppressed by incorporation of N-acetylcysteine.
Next slide, please. For the recommendations for the safe and effective use of supplements with regards to age, most of the studies gathered utilized participants who are above 18 years old, although some investigations on vitamin D, magnesium, and curcumin have been based on children and teenagers. High-dose supplementation of vitamin D in older age groups, particularly dosages of 250,000 IU to 500,000 IU for treatment purposes, is found to be helpful. Curcumin also showed promising results. None of the curcumin studies reported adverse effects, hence the 500 to 1,000 milligrams once a day or 40 to 90 milligrams twice a day may be taken, but it depends on the age of the person. Next slide, please. On the other hand, the application of 2 grams of magnesium on 4 years old children, which is at least 15 times greater than the recommended intake established by the United States National Institute of Health, was found to be ineffective for treatment. Lastly, high dosage of vitamin C in older age groups was also found to be non-beneficial. For recommendations based on health status, it has been discerned that people supplemented with A, D, C, E, B6, B12, folic acid, zinc, selenium, copper, and iron are effective for the prevention of runny nose and cough. The same can be said for the administration of 50 UG of vitamin D3 or 7 drops of vitamin D on healthy people, as the results of the studies on them showed no significant effect on the severity, but has showed promising results in the reduction of incidences of viral illnesses in the future. A combination of vitamin C, hydrocortisone, thiamine was deemed effective for the treatment of pneumonia, similar with the high-dose supplementation of vitamin D and administration of 40 to 1,000 milligrams of curcumin, depending on the age and severity of the illness. providing supplements enriched with vitamin A, E, C, zinc, and selenium is efficacious for patients suffering from COVID-19. Notably, 40 milligrams of curcumin once a day is enough to help in the treatment of patients. However, the combination of vitamin C 3 times a day and zinc before bedtime was deemed ineffective. High-dose supplementation of 4 milligrams of selenium, on the other hand, has the potential to alleviate the illness of critically ill patients with acute respiratory distress syndrome. Virgin coconut oil is also heralded as a potent immunity enhancer on COVID-19 suspect and probable patients. People may take 0.6 ml of virgin coconut oil per kilogram body weight for days 1 to 3, and then increase it to 1.2 ml per kilogram body weight for days 4 to 28. Lastly, septic shock patients and individuals with acute respiratory infections are recommended to have supplements with various combinations of antioxidants in them, as they are deemed more efficacious in the treatment of the aforementioned viral illnesses.
Next slide, please. So, based on the findings of the conducted study, the researchers concluded that the food supplements that have the potential for effectiveness specifically against COVID-19 are the virgin coconut oil, the curcumin, selenium, and those supplements with various combination of antioxidants. Second, a supplement that incorporates more types of antioxidants is more potentially effective in improving the health of a susceptible and or probable person infected with COVID-19. Additionally, curcumin and selenium supplementation can significantly decrease and suppress the expression of interleukin 6, wherein its increased levels can be correlated with the severity of COVID-19 infection. On the other hand, incorporating N-acetylcysteine can be potentially effective in the suppression of tumor necrosis factor alpha. Finally, beneficial dosage of antioxidant food supplementation may vary based on the patient's age group. Meanwhile, patients with COVID-19 and other related respiratory disorders are encouraged to take antioxidant supplements with various combination of vitamins such as A, E, C, zinc, selenium, and curcumin for a significant antiviral effect.
So for future researchers, we can recommend that they must gather more randomized controlled trial studies with larger sample population of not less than 100 that utilizes using antioxidant as an immune booster against illnesses and symptoms similar to COVID-19. We also recommend that they gather articles and studies with standardized measurement for viral outcome, particularly with more focus on the suppression of interleukin 6 and tumor necrosis F alpha, with more focus on supplement incorporating various combination of ingredients. Thank you very much.
Thank you, Group 2. And finally, the third group who will discuss about the saliva as a diagnostic specimen for detecting SARS-CoV-2, a meta-analysis. Ladies and gentlemen, let us welcome Ms. Egina Festin, Ms. Daniela Caponpon, and Ms. Christine Velasco.
Again, a pleasant afternoon. Thank you very much for this opportunity to present our research in front of all of you. Now, let me introduce my group first. I am Gina Festin, the leader of our research group, and these are my group members, Daniela Caponpon and Christine Velasco. Currently, we are all in our fourth year in BS Medical Technology. Carrying on, we are going to present our thesis entitled Saliva as a Diagnostic Specimen for Detecting SARS-CoV-2, a Meta-Analysis. So, shown on the screen is the outline of our presentation. After a brief discussion and an overview of the methodology, we shall proceed with the key findings and thereafter the conclusions and recommendations. So COVID-19, a respiratory disease that first appeared in China, has spread worldwide, resulting in over 180 million confirmed patients and 4 million deaths as of today. Currently, upper respiratory specimens such as nasopharyngeal swabs are the primary diagnostic specimens in the detection of SARS-CoV-2. Although samples obtained from nasopharyngeal swabs are known to be the gold standard in terms of obtaining accurate results, these tests require more equipment, bring healthcare staff in direct contact with potentially infectious people, and are difficult to scale up for the mass testing. So we all know that there is a need for massive SARS-CoV-2 testing in this current pandemic. That is why the search for a substitute diagnostic specimen in the diagnosis of COVID-19 continues to be an interest among researchers like us since last year. This has motivated us to conduct a search for an alternative diagnostic specimen with high diagnostic accuracy and short turnaround time. In line with this, saliva has been put forward as a low-cost, readily available alternative, but its efficacy and accuracy still need to be studied further. The measures of diagnostic accuracy of SARS-CoV-2 detection using RT-PCR based on saliva and nasopharyngeal swab should be compared, and it is in this context that this study is created. So with that in mind, the main research problem is to comparatively analyze the potential diagnostic value of saliva in the detection of SARS-CoV-2 against that of the nasopharyngeal swab. Specifically, how do saliva compare with nasopharyngeal swab using different measures of diagnostic test accuracy, such as sensitivity, specificity, positive predictive value, and negative predictive value? And is the standardized mean difference in diagnostic accuracy favorable to saliva or to nasopharyngeal swab? Our hypothesis is that saliva is not comparable to nasopharyngeal swab in terms of sensitivity, specificity, positive predictive value, and negative predictive value in the detection of SARS-CoV-2. So the scope of this presentation is that it only covers the results of observational studies that have already been published internationally and locally from January 2020 to March 2021. These are studies that focus on the diagnostic accuracy of saliva in the detection of SARS-CoV-2. And the target population, the setting, the time frame, and other variables would be dependent on the included studies, which were taken from PubMed, Medline, and Cochrane. Majority of the limitations of this study revolves around the heterogeneity that was found in the studies, that is the population and the methodology. So this may produce bias that may lead to overestimation of diagnostic accuracy and a decreased reliability of the results. So we should also take note that other databases were not included and that a study by RITM was also not included. The literature in salivary diagnostics for COVID-19 is indeed overwhelmed with inconsistencies. The diagnostic accuracy of saliva as a diagnostic specimen in detecting SARS-CoV-2 is still to be established through further research. So the conceptual framework that we have adopted in our study is essentially an input, process, output, or IPO model. For the input, different observational studies regarding the use of saliva and nasopharyngeal swab specimens in COVID-19 diagnostics were collected, and then the data extraction and assessment criteria were strengthened using PRISMA. For the assessment of biases and heterogeneity between studies, the researchers used Cochrane's Q and I-squared tests. And to see the comparability of the two, the saliva and NPS, the results were pooled and compared using a fixed effects model. Data gathered with regards to the diagnostic accuracy of both saliva and nasopharyngeal swab specimens were then tabulated for comparison and analysis. So after this analysis, it is expected that the diagnostic accuracy of saliva in detecting SARS-CoV-2 will be estimated and when compared against that of the current gold standard, which is nasopharyngeal swab. So this is a procedural framework of our study, and it shows the general flow of the procedures done throughout our study. This study is carried out to evaluate the available data regarding saliva as the diagnostic specimen in SARS-CoV-2 detection as compared to the current reference standard, which is nasopharyngeal swab, published at March 2020. So we did systematic searches for the records after January 1, 2020, and the database and the cited and citing papers of the relevant studies were also screened for further eligible studies. These are the inclusion criteria that we have used during our study selection. The studies were considered if they met the following criteria. First, if the studies published in peer-reviewed journals or reputable publications. Second, if the index test of these studies is saliva specimens with PCR diagnostics for detecting SARS-CoV-2, and if the reference standard used is NPS specimens with PCR diagnostics. And fourth, if the studies were directly compared saliva and nasopharyngeal swabs for the detection of SARS-CoV-2. Fifth, the studies provided enough data to construct 2x2 diagnostic table, or studies that provide data regarding the test specificity and sensitivity. And six, if the records were written in English. So eligible studies also utilized paired saliva and nasopharyngeal tests done on the same date on the same persons presenting for SARS-CoV-2 testing.
On the other hand, the exclusion criteria were the following. First, publications with no primary results, such as reviews, guidelines, and recommendations. Second, not peer-reviewed studies. Third, studies or publications dated before January 1, 2020 and after March 15, 2021. Lastly, those studies with sample sizes lower than 10 patients. Now, back to our procedural framework again. After our database search, we gathered our data using a pre-constructed standardized data extraction form with the following information to be extracted. First, author's name, year of publication, place of study, study type, population size, age, gender, method of diagnosis, type of PCR kit, and the following outcome parameters such as number of total positive and negative saliva tests and numbers of total positive and negative nasopharyngeal swab tests. On the third box, after the data collection, the sensitivity, specificity, positive predictive value, negative predictive value, and the diagnostic accuracy data of saliva and nasopharyngeal swab and the included studies were calculated using the raw data, such as the true positives, false positive, true negatives, and false negatives. On the fourth box, the heterogeneity was assessed using the Cochrane Q and I-squared test. On the fifth box, the results were then pulled and analyzed using a forest plot with the standardized or the standard mean difference as the effect measured to determine the comparability of saliva to NPS in COVID-19 diagnosis. Now let us start discussing the results of our study. Here you can see the flow of our study selection. The database searching of Cochrane Library, PubMed, and ScienceDirect yielded 96, 38, and 317 studies. The researchers only included studies that were published at the start of 2020 to make the search more specific to COVID-19. 62 studies were reviewed by reading the full article after 214 studies were excluded during the title abstract screening. The researchers screened further studies from the cited references. The studies we included have differences and similarities that are noteworthy. There were 5,697 samples that were tested, and from these, the mean number of sample pairs was 317. However, it should be noted that the sample size in each study varied significantly, ranging from 10 to as many as 1,924. The studies varied by setting and patient population. Although the United States was the most highly represented country with 4 studies, there were also studies from the Philippines, Japan, Thailand, UK, France, and UAE. The studies also used different types of PCR kit, The studies included patients that are more than 18 years old. The number of males and females in each study also varied from one study to another. The study type also differed. Most of the included studies were prospective cohort studies, but there were also cross-sectional, retrospective cohort, and mass screening studies. The researchers also assessed the risk of bias in the 16 studies according to the Quadrant 2 tool. 5 of the 6 had low risk of selection bias. On the other hand, 4 studies had high risk of bias in the index test due to the fact that the saliva test results were interpreted with prior knowledge of the results of the reference standard. Flow and timing were high or unclear in all studies, since there was no exact information regarding the time passed between specimen collections for the two tests. Applicability had low concerns in the index test in 4 studies and unclear in 2 studies. Altogether, the risk of bias analysis demonstrated a moderate bias level in both the individual and the overall aspects of the studies. So now, allow me first to discuss the summary of the sensitivity, specificity, precision, and accuracy of saliva as compared to nasopharyngeal swab in each study. In Table 1, it can be seen that Basso et al. Study had the highest sensitivity of 100%, followed by Bass et al. Study with 94.37% and Hansen et al. Study with 92.59% in true positive rate. Basumsub et al. Study had the lowest sensitivity of all the studies at 1.10%. T et al. Study had the highest specificity of the others at 100% compared to 99.68% for Yokota et al. Study. The study of Hooper et al. Comes next with a result of 99.20%, whereas Pasumsub study yielded the lowest specificity value of 15.79%. T et al. Study had the highest precision of about 100%, followed by Bass et al. With a value of 97.10%. Hanson et al. And Sugimoto et al. Had 93.75% positive predictive values. On the other hand, Pasumsub et al. Research had the lowest precision, which was 11.11% of all the studies. Given the results of negative predictive values from the 16 included studies, 12 studies had above 90% negative predictive value. Only the study of Basso et al. Had 100% negative predictive value, and the lowest negative predictive value, which was 1.65%, came from the study of Pasumsub et al. In terms of accuracy, the Kota et al. Study had the highest result of 99.48%, followed by T et al. Result with about 98.74%. Again, Pasumsub et al. Research has the lowest accuracy of about 2.5%. To summarize, the sensitivity for the index test was high in 13 out of 16 studies. The study by Basso et al. Had the highest sensitivity value, whereas T et al., which was a local study in the Philippines, had the highest specificity and precision values. Yokota et al. Study, which was followed by T et al., had the highest accuracy value. In terms of negative predictive value, 14 out of 16 included studies had greater than 80% negative predictive value, which represented correctly diagnosed individuals who were with negative test results. And only the study of Pasumsub had the lowest results in terms of sensitivity, specificity, accuracy, negative predictive, and positive predictive values. In addition, the pooled specificity value of saliva, which was about 98.17%, was the highest among the pooled values, whereas the pooled sensitivity value of 68.5% was the lowest among the pooled values. The values obtained in terms of sensitivity, specificity, precision, and accuracy values differ from each study due to sample size and the method implemented for the fulfillment of these studies. So on the other hand, the findings regarding the measures of diagnostic accuracy of nasopharyngeal swab were summarized in Table 2. The T et al. Study had the most participants of about 238 compared to 57 participants for Chigumoto et al. and 175% et al. The study of Chigumoto et al. Had the highest sensitivity value of 100%, whereas T et al. Had the lowest sensitivity of 74.07%. P et al. And Sun et al. Had the highest specificity and precision, which was 100%. All of the studies included had greater than 95% negative predictive value. Among this, only the study of Sugimoto et al. Had 100% negative predictive value. As regards accuracy, the study by Sun et al. Obtained the highest accuracy value of 99.43%, and the study of Sugimoto obtained the lowest accuracy value of about 85.96%. Lastly, the values of specificity and negative predictive value had the highest pooled values and are of the same values, which were 97.48%. On the same line, the values of positive predictive value and sensitivity were the same and the lowest among the pooled values, which was 94.74%.
We also calculated the standardized mean differences, or SMD, in diagnostic accuracy of the included studies. This is the forest plot, which indicates the heterogeneity and the SMD in diagnostic accuracy of the 16 studies, including their pooled result in the last row. Since the I-squared value is more than 50%, fixed effect model was used to assess the effect of each study on the overall results. The boxes show how much influence the study have on the pooled result. The bigger the sample size, the higher the percentage weight. The larger the box and more the influence of the study has. This implies that the study by Yokota et al., Huber et al., and Torres et al. Have the most impact in the studies. The horizontal lines through the box illustrate the length of the confidence interval. The longer the lines, the wider the confidence interval, the less reliable the study results. The vertical line at 0.00 is the line of no effect. None of the studies cross the line of no effect, which is the 0.00. Therefore, all of the studies are significant. This is also true for the pooled result, which is given by the last row in the figure, indicating that the difference in the diagnostic accuracy found between the NPS and saliva is statistically significant. Another thing is that standardized mean difference less than 0 favored NPS, whereas the above 0 favored saliva. Therefore, as seen in this forest plot, all the included studies except the study of Pasumsub et al. Favor saliva as a substitute of NPS as a diagnostic specimen for COVID-19. The same is true with the result estimate, which is also located to the right of the line of no effect, indicating that the pooled result of the 16 studies favors saliva as a good substitute for NPS. Upon the assessment of heterogeneity, the Q value was found to be 2156.503, while the degree of freedom is 15. P value is 0.00 and I-squared value is 99.304%, indicating that this meta-analysis has considerable heterogeneity. This is mainly due to the study of Pasumsub et al., since it failed to establish that saliva can be substitute for NPS as a diagnostic specimen for COVID-19. In the table 3, the summary effect is found to be 0.838 with a z value of 99.382. and the p-value of 0.00, indicating that it is statistically significant. This means that the effect observed in the study is greater than what would be expected by chance. The following are the findings of the study. The pooled sensitivity of the index test in the 16 studies was found to be 68.50%. 13 studies showed high sensitivity, which is greater than 50%, of saliva specimen in SARS-CoV-2 detection. The specificity was calculated and found to be 98.17%. On 1 out of 16 studies demonstrated an unfavorable specificity, which is 15.79% for the saliva specimen. The overall positive predictive value of the index test in the 16 studies was found to be 87.33%. However, there is one study that showed low positive predictive value for the saliva with a value of 11.11%. The overall negative predictive value of the index test in the 16 studies was found to be 94.42%. 14 studies demonstrated a negative predictive value that is greater than 70%. The overall accuracy of saliva as a diagnostic specimen is 93.56%. The standardized mean difference is found to be 2.540, which indicates that the pooled result favors saliva as an alternative diagnostic specimen in COVID-19 diagnosis. Based on the findings regarding problem number 1 and 2 in this study, the researchers concluded the following. First, saliva has the highest pool specificity value, which is 98.17%, as compared to nasopharyngeal swab, which only had a 97.48%, but nasopharyngeal swab pooled values in terms of sensitivity, which is 94.74%, positive predictive value, which is 94.74%, and negative predictive value, which is 97.48%, and accuracy, which is 96.60%, were higher than the saliva. However, it should be noted that the number of studies from which the pooled result of saliva and nasopharyngeal swab are not equal, so it would be the best that this comparison be interpreted with caution. 2. The combined standardized mean difference is found to be 2.540. Therefore, the pooled result favors saliva as an alternative diagnostic specimen in COVID-19 diagnosis. 3. Saliva exhibits an outstanding diagnostic accuracy, which is 93.56% in COVID-19 diagnosis, and even the pooled standardized mean difference of the 16 studies favored the use of saliva as a substitute for nasopharyngeal swab in SARS-CoV-2 detection. From these findings, it can be concluded that saliva is comparable to nasopharyngeal swab in terms of specificity, sensitivity, positive predictive value, negative predictive value, and overall diagnostic accuracy. However, due to the high level of heterogeneity that was observed among the studies, conclusions from this meta-analysis warrant a careful interpretation. Based on the preceding findings and conclusion of the research, the researchers offer the following recommendation. First, future researchers may compare or look at the difference of serological and salivary tests when it comes to SARS-CoV-2 detection. Future researchers should also make comparisons of other alternative specimens such as urine, stool, and blood for detecting SARS-CoV-2. The future researchers should gather more raw data from the original authors to allow more in-depth analysis. The future researchers should collect studies that have more or less equal sample sizes to allow more room for comparison. Future researchers should incorporate more eligibility criteria that may reduce the heterogeneity of the selected studies and increase the validity of entire meta-analysis. Right then, as we hope to have shown this afternoon, saliva has the potential to become an alternative specimen for nasopharyngeal swab in COVID-19 diagnosis. With a high diagnostic accuracy of 93.56%, we can say that the saliva is comparable to nasopharyngeal swab. We hope that this study will help in more efficient diagnosis of COVID-19 in the near future. Thank you for listening.
Thank you very much for our all thesis presenters. And at this point, we shall entertain some questions from our viewers about the presented thesis. So for the group one, we will have two questions. We will have the first question as, how did you apply the multi-criteria analysis in your study? And then the other one is, given the online setting in conducting your research, what limitations did you encounter?
Thank you for that question. So, the multi-criteria analysis, we applied it to the attributes of the COVID-19 vaccine brand. So, to put it another way, the attributes in our study was used as the multi-criteria and the respondents' preferences of COVID-19 vaccine. So, essentially, multi-criteria analysis is used in research to determine the preferences of respondents for a particular brand. So in our study, that would be the COVID-19 vaccine brand, wherein the respondents will choose a specific brand based on the attributes before being considered getting vaccinated. So for the second question, the limitations that we've encountered, primarily it would be the we weren't able to conduct face-to-face dissemination of our questionnaires. But the advantage of it is that we were able to gather respondents in a short period of time, who are people residing in Bacoor, Silang, Dasmariñas, Tansa, and Imus. And those respondents were ages range from 18 to 80 years old. Thank you.
Thank you, Group 1. And for Group 2, here are the questions. For our first question, what are your criteria in the inclusion of a particular supplement in the study? And for the second question, how did you ensure the validity of your study?
Um, for the first question, we have no specific preference for the kind of antioxidant in our study that we include in our systematic review. A particular supplement is included if it meets the overall inclusion criteria set for our study, which was already mentioned before. More specifically, the supplements were included if they are used to treat COVID-19 diseases or similar to the manifestation of COVID-19. If it was also used on a clinical trial against COVID-19 or similar to it, specifically using randomized controlled trial, and if the effects were denoted, especially on interleukin 6 and tumor necrosis factor alpha. It also doesn't matter if it's effective or not in the results of the study, we will still include it because the goal of our systematic review was to compile all available literature in our topic and then compare them with each other to answer the research problems. Now, in order to ensure that the results are reliable, we use the JADAD scoring. Can I hear again the second question? Sorry.
For the second question is, how did you ensure the validity of your study?
Oh, Angelica, do you want to answer that?
Yes, yes. How did we ensure the validity of our study? First, we establish a definite set of criteria. That's the base or the skeleton of our study. It's easy to get overwhelmed by the amount of literature available when conducting a systematic review, right? So, having a clear and defined eligibility criteria really helps us in sorting out the ones that do not meet the standards we have set for our study. And additionally, in many cases, the types of study design will also be a key component, one of the secret. So, for example, in our study, we chose the randomized controlled study as the study design of those literature na sineselect namin because it's considered as the gold standard for intervention-based investigations. And such as study nga namin na antioxidant supplements that have potential effectiveness against COVID-19. So, A1, do you want to add anything?
Yeah, sure. So we also use the JEDA skill in order to establish the research methodology quality of the chosen studies. So basically, it ensures that the reliability of the study and the reliability of the results. So furthermore, we also made sure that the article that we have included in our studies were peer reviewed and they were also from a reputable institution. Thank you for.
Thank you very much, Group 2. And lastly, for our last group, we have two questions. For the question number one is, do you think the values you obtain, such as accuracy, NPV, PPV, sensitivity, and specificity, were enough to determine the diagnostic significance of the specimens, either saliva or NPS? And the second question is, why did you only include studies that conducted paired saliva and NPS testing?
Thank you for those questions. First, I would like to answer the first. We think that these values regarding the accuracy, NPV, positive predictive value, sensitivity, and specificity were enough to determine the diagnostic significance, since these measures of diagnostic accuracy, as stated by Cochrane, are enough parameters in terms of actual accuracy of NPS and saliva specimens. Regarding the question number two, um, we conducted purge saliva and NPS testing, since there would be a higher heterogeneity if we did not include purge saliva and NPS testing because of different sample sizes and methods implemented from specific studies with only NPS or saliva testing. Then this would cause a higher level of heterogeneity. That's why in our case, we conducted purge saliva and NPS testing, leading to only a considerable heterogeneity. Supporting this claim, based on our result of the I-squared value, which was equal to 99.304%, this indicates that our meta-analysis has considerable heterogeneity. Considerable heterogeneity due to the fact that Pasumsub et al. Study failed to establish that saliva could be a suitable or substitute for NPS as a diagnostic specimen for COVID-19. Hence, a high level of heterogeneity is not unique in our study. Thank you.
Thank you very much to our speaker and thesis presenters for sharing a wonderful and very enlightening talk and for sharing their precious time with us today. Once more, may I now call Sir Toriano to present the Certificate of Appreciation.
Thank you very much for that wonderful sharing of yours. Three groups have presented their theses, which were all conducted last year. And I am glad to announce that they have been accepted all for publication in the Philippine Women's University Research Journal. The Philippine Women's University School of Medical Technology presents this Certificate of Appreciation to the following. For Group 1, we have Rania Maulana, Shanin Marie Duminia, Andrea Kate Ligaspi, Veronica Jean Malay. And for Group 2, we have Felina Beatrix de Guzman, Angelica Mendaros, Karl Marx Simangan, and Iwon Chibatu. And for Group 3, we have Agina Joy Festin, Daniela Capunpon, and Christine Velasco as thesis presenters for imparting invaluable knowledge in the Research Forum 2 in Focus, Microscopy and Research conducted on the 18th day of November 2021. Again, thank you very much and congratulations.
And the pandemic in the second year of running its course has presented many challenges, but despite these, some of our medical technology students still attained exceptional marks. Let us recognize and congratulate the Dean's Honorees of the first trimester of school year 2020 and 2021.
Okay, thank you very much. Now allow me to share my PowerPoint. I hope this is already visible to all of you. The Philippine Women's University School of Medical Technology is proud to present our academic achievers in the first trimester of school year 2021 and 2022. The Dean's Lister is awarded a star corresponding to the attained general weighted average. For the Gold Star, students attaining a general average of 1.0 up to 1.20. For the Silver Star, we are giving the Silver Star Award to students garnering an average of 1.21 up to 1.40. And for the Bronze Star, they are the students garnering an average between 1.41 up to 1.50. So let us begin with the first year awardees. Balbanida Gwyneth Rain, Silver Star, with an average of 1.338. Next, we have Bona Ivana May, Silver Star, with an average of 1.206. Next, we have Kabansag Krisha May, Silver Star, with an average of 1.294. Next in line, we have Daguman Cassandra Maris, also Silver Star, with an average of 1.221. Next, we have Imbate Ira Marie, Silver Star, with an average of 1.338. Next, we have Esibes Megan, also Silver Star, with an average of 1.294. Next, we have Hilvano M. June, Golden Star, with an average of 1.162. We have Pastor Fide Raven, Bronze Star, with an average of 1.411. Next, we have Rasul Feya, Silver Star, with an average of 1.250. Reyes Shannon, Silver Star, with an average of 1.338. Cernetches Mark John, Silver Star, with an average of 1.206. Toledo Astro Juliana, Golden Star, with an average of 1.162. Olayaw Ann Neriel, Golden Star, with an average of 1.132. Velas Danica May, Golden Star, with an average of 1.162. And now let us proceed with the second year honorees. We have Hongria Jan Naomi, Silver Star, with an average of 1.391. And lastly, we have the fourth year students. To begin with, we have Festine Egina Joy, Bronze Star, with an average of 1.5. Followed by Ligaspi Andrea Kate, Bronze Star, with an average of 1.4 446. And finally, Maulana Rania, Bronze Star, with an average of 1.46. So congratulations, guys, and keep it up.
Thank you, Sir Sherwin. Congratulations, guys, and may this recognition serve as an inspiration to all of us. Continue to study well, keep moving forward until you have achieved your professional license. Once again, congratulations. To wrap up this very informative and insightful forum, may I call on our School of Medical Technology Graduate School Coordinator, Dr. Nini Festin Lim, for the closing remarks.
Thank you. First and foremost, on behalf of the faculty and students of the School of Medical Technology, I would like to express my thanks to Mr. Marco Alfredo Benitez, University President, for his dynamic leadership and inspiration in all the activities of the department, especially in conducting research. And to Dr. Felina C. Young, Chancellor and Senior Vice President for Academic Affairs, for untiring support to the School of Medical Technology. My deepest gratitude to Dr. Frederick Llanera, our distinguished guest speaker today, for sharing his expertise and thoughts on the topic microscopy, an invaluable tool for experimentation. And to all the presenters for sharing their research outputs with the PWU community. Through research, we certainly can find solutions to many problems that confront us during this COVID-19 pandemic. The School of Medical Technology, an academic department of the university, is tasked to ensure implementation of research as one of its academic functions. Hearing and listening to the speakers have helped us understand and appreciate the importance of research as a development tool to address many issues and problems in the country. It is important that we regularly update ourselves with the current researches that could affect our health, lifestyle, economy, and policies. Certainly, the information we learned from this webinar will further encourage everyone to pursue relevant research endeavors. Would be appropriate and useful to summarize some of the ideas and findings emanating from this webinar. It will be useful to consider them in formulating new research topics in the future. And I would like to thank Dr. Llanera for giving us many suggested topics for research. Obviously, the webinar achieved its objectives: elevate the standards of medical technology research by enriching the awareness of students, preparing for and already conducting their studies for a successful and a more contributive study in the field of laboratory science. Strengthen collaboration among students, academicians, laboratory practitioners, and other professionals, that they may find a common ground to explore and substantiate knowledge and information by working together. To build a positive and invigorating culture of research through the sharing of best practices and the relevant experiences. Dr. Llanera has effectively explained the importance of microscopy as a laboratory tool in the diagnosis of various diseases and how microscopy has been used in the different areas of the laboratory. The current developments in technology has made microscopy more important in medicine. At the same time, microscopy has also been stressed by Dr. Lanera, how it can also serve as an invaluable tool in research, especially in experimental research. We are also happy that this webinar has given our student researchers the opportunity to share and disseminate their findings with the PWU community. There were a number of points raised in the studies presented. Some of these highlights were saliva is comparable to nasopharyngeal swab in terms of sensitivity, specificity, accuracy, predictive values, and overall diagnostic accuracy in the detection of SARS-CoV-2. However, there is one limitation, and that is due to the high level heterogeneity among the studies. The use of saliva has to be considered with caution. The use of supplements is a reinforcement in boosting the immune system against the infection. People has an easy access to it as it can be bought over the counter at the pharmacy and be quickly incorporated in our daily diet. Pfizer BioNTech was the most well-known vaccine brand among the respondents. The preference for safety in selecting a COVID-19 vaccination was the most prominent among the other attributes mentioned. On this note, I would like to convey our special thanks to Mr. Sherwin Toriano, Program Chair, School of Medical Technology, for organizing this research webinar, and to all the working committees who have been extremely cooperative in implementing the needed requirements of the webinar. Finally, my deepest thanks are of course reserved for the PWICT, Multimedia and Marketing Department for their priceless contributions and for running a smooth virtual event. Most of all, to all of you, the attendees, for your active participation. Without all your contributions and participation, this event would not have been possible and successful. We hope to see you again in our future webinars. Thank you and stay safe.
Thank you very much, Dr. Nini Festindim. And with that note, let us call it a day. For the final announcement, kindly enter the evaluation form after the forum. The evaluation form can be accessed through the QR code flash on the screen. The code along with the link will also be posted in our official MedTech Facebook page. The release date of certificates will be on or before November 30. Thank you for joining us, fellow women.
We hope to see you in our future events. Don't forget to wash your hands, eat healthy foods, observe physical distancing, and follow the health protocols. Let us all remain strong during this pandemic. It is with great hope that this will come to pass soon. Again, I am Astrid Toledo.
And I am Kiana Clarissa Morla. We are your Masters of Ceremony. Thank you and have a safe afternoon.